Hello, this is Dr. Eric Bricker, and welcome to A Healthcare Z's training session on healthcare finance fundamentals. Thank you all so much for being here. And we have a fantastic group today, literally from around the world. We have people from 15 countries that have registered for this training session. And here in America, we have folks from like over 30 states as well. So I'm super excited to share with you healthcare finance fundamentals training. And we're going to do something a little different. I'm actually going to use slides. So I'm going to start off by going to the title slide, and then we'll jump right in. Now, remember that you can ask questions and leave comments in the comment section of either LinkedIn or YouTube, whichever platform you're watching, and I'll be able to see them on my end. So please ask questions as we go along, and I will pause periodically to answer those questions during the presentation. So there we go. Fundamentals of healthcare finance, and we begin. Now, many of you know me, but I want to briefly go over my background. So before I became a physician, I actually was a hospital finance consultant because, believe it or not, hospitals have a hard time getting paid. So they hire outside consultants to come in and show them how to do that. So I did this for a number of academic medical centers around the country: University of Kansas Medical Center, Cleveland Clinic, a Yale Associated Hospital in Connecticut. And I learned all about the billing and the coding. And really, this was a sort of a payment mess. And this was back in the 90s. So this was over 20 years ago. And I still wanted to become a physician, but I just saw the struggles that not only the hospital and the doctors were having, but also the patients were having in terms of their healthcare costs and the financing in healthcare. So I knew I wanted to be a part of that in my career. And so then went on to medical school at the University of Illinois College of Medicine, which is actually in Chicago, and then did my residency in internal medicine at Johns Hopkins in Baltimore. Fantastic experience. Then actually practiced as a hospital physician. One of the big healthcare systems here in the Dallas area is called Baylor Scott and White, and I was at one of their community hospitals in a town called Plano, which is a suburb of Dallas. And then I actually started a company with some partners, and they are I'm sorry, I'm pausing because people are saying they've got a black screen. Okay, let's go back. We'll go to this. Okay, thank you for your feedback, everybody. Can you see me now? Let me know in the comments section if you can see now or not. Okay, you're saying to try refreshing. Okay, couple bumps in the road. That's okay. Great. Thank you so much, Dana and Christopher. So they recommend refreshing your screen. So try refreshing your screen if you can't see it. So actually started a company with several co-founders called Compass Professional Health Services that Okay. Thank you for your continued feedback. So Compass Professional Health Services is what's called a healthcare navigation firm. So we actually would contract with employers to help employees with their health insurance, because this was starting back in 2007 when these HSA consumer-directed plans were just starting. So the employers were like, okay, now you've got your copays are going away, and now you've got this deductible, but we're going to give you some money on an HSA card. And all the employers were like, okay, I have no idea how to use this thing. And so they would hire our company, Compass Professional Services, as the healthcare navigation service that we had folks on the phones and on the emails, and you could interact with them through our app as well, where we would provide price and quality, transparency information. We would resolve problem bills. We'd give you information about the pricing of medications. We'd find the specific doctor you could need for. We basically took care of all the administrative cost stuff in healthcare, except for the clinical decisions. So the doctor and the patient, they still were seeing each other, and the two of them were still making all the clinical decisions. And then our Compass Health Pros were taking care of everything around that to make it happen. And we grew that to over 2,000 employer clients. You can see some of the big name employers we had there: Southwest Airlines, T-Mobile, Chili's, Maggiano's Restaurants. We sold that business to a company called Alight Solutions, which was actually a spin out of Aon. And we did that in 2018. And then what I did is I worked with employers for over 11 years and their broker benefit consultant, explaining how healthcare works and how Compass could help them. And so I saw that there was still a tremendous amount of misunderstanding in how the US healthcare system worked. And so I'm like, okay, well, why don't I just make some videos about that? And that's what started A Healthcare Z, was me explaining healthcare finance on LinkedIn and on YouTube. And it's actually grown to over 300 videos. We actually have over 120, it's pushing 130,000 views a month. So I really appreciate all of you tuning in and watching these videos. And then I was asked recently to become the medical director for Simple Pay Health and Coop Health, which is sort of two brands for the same company, where we're actually providing a zero deductible copay only plan, because the pricing obviously in healthcare is so confusing that we found that the only way to really guarantee the pricing was to give people copays. Now, there were varying ranges of copays, et cetera. But if you give somebody the copay, then you can actually give them price certainty in advance. So let's go on to the finance training. So now, if we're going to talk about finance in healthcare, then we have to talk about the bills, because the bills is literally how the money changes hand. Okay, so and in order to talk about the bills, we have to talk about the coding. So the bills are filled with codes. And if you work in healthcare and healthcare finance, then at a basic level, you have to understand these codes. Okay, so the first code is the ICD-10 code. And the ICD stands for the International Classification of Diseases. It is the 10th revision. Here in America, we used ICD-9 from the 1970s until 2015. So it was sort of a big shift when we moved from 9 to 10. And the ICD-10 code, that's the diagnosis code. So all bills have a diagnosis on them. And that diagnosis could be like pneumonia or diabetes. And then that ICD-10 code is typically, it can be as few as 3 digits. And then there's typically a dot. And then there can be up to 4 digits after the dot. So there's a total of 7 digits maximum. Not all ICD-10 codes have 7 digits, but it can be that long. And it's alphanumeric. It's a combination of numbers and letters. Now, that diagnosis can also just be a symptom. It can be like cough. Okay, so a cough is not a disease. It is not a diagnosis. It's just a symptom. But when you just walk in and you have a cough and you're not exactly sure what's going on yet, whether it's bronchitis or asthma or pneumonia, what have you, but you still need to code it as something, then you can code it as a cough. Likewise, if you go in for a wellness visit, just an annual physical exam, well, nothing's wrong with you. You're just alive, right? So there's no code for being alive. And so there actually is a diagnosis code just for a preventive visit as well. Okay, next code is the CPT code. And the CPT stands for Current Procedural Terminology. And the CPT code is then, okay, well, what's done about that diagnosis? So the CPT code, probably the most common one that's used, is referred to as the E&M codes, or the Evaluation and Management codes. And an E&M code is it's a CPT code. And all CPT codes are 5 digits. They're all numbers. All the E&M codes start with 99. So it's real easy to find all the evaluation and management codes. So that's like for an office visit. So a 99201 is for like a new patient office visit. Now, there's also CPT codes for what could be done. It could be a lab test. So there's a CPT code for a lab test, whether it be a complete blood count or a cholesterol panel, et cetera. There are CPT codes for procedures. So it could be like a colonoscopy or an upper endoscopy. There are CPT codes for more major surgery, like a coronary artery bypass graft, or for labor and delivery. So what's done about the diagnosis is the procedure, the CPT code. So all bills need to have the ICD-10 and the CPT code. Now, that's for outpatient. Now, for inpatient, when you're actually admitted to the hospital, then there's something referred to as the diagnosis-related group, or the DRG. Okay, so DRG codes are only used for inpatient billing. If you go to a hospital, and let's just say you have your blood drawn at the hospital, or you have an MRI done at the hospital, but you're not admitted. A lot of testing is done on an outpatient basis. Even procedures are done on an outpatient basis at the hospital. There is no DRG code for that. You're only going to get an ICD-10 code and a CPT code. But if you're actually admitted, let's say you have a 3-day hospital stay for pneumonia, then you will have a DRG, a diagnosis-related group. And then the reimbursement is based upon the DRG in that situation. Okay. Lastly, we have the Hicks code. So HCPCS is actually pronounced Hicks for short. And a Hicks code, because of course, the ICD-10 and the CPT codes and the DRG codes, it wasn't enough codes. We had to have more codes. And so a Hicks code is typically used for things like specific infusion medications at a hospital. And typically they'll start with like the letter G or the letter J. So sometimes they're just referred to as J codes, but there are sometimes, not all bills have to have a Hicks code, but just know that you can see additional codes on a bill as well, and that will be the Hicks code. Okay, now, so you've got all these codes that go on the bill. Now, there's 2 big categories of bills. So there are the professional fees or the pro fees, and those bills are called HCFA 1500. So I'm a physician. I would send a physician bill on a HCFA 1500. And then there are the facility fees for the actual hospital or ambulatory surgery center or what have you. And that would be the UBO4 is the facility bill. So those 2 bills are sent in. And those same bills, the HCFA 1500s and the UBO4s, they're used whether you're billing Medicare or commercial insurance. They're all the same. Now, what I'm going to do now is I'm going to explain to you then, once those bills are received by the insurance company, I'm going to explain to you how then they are repriced or that discount off of billed charges. And what I have here is a grid that's going to help me explain sort of what happens at the negotiating table between insurance carriers and hospital systems when they negotiate their contracts. Okay, so the insurance carrier goes to hospital A and says, okay, we got to negotiate our prices here. And hospital A says, okay, we want $2,000 for every MRI that we do. And that's the allowed amount. That's after the discount. So the bill charges could be $3,000, $5,000, $10,000. That allowed amount that the insurance company is going to pay out. The hospital's like, we want $2,000 for every MRI that we do. And the insurance company comes back and says, whoa, well, that is, a lot of money, but we'll go along with it. Now, that same insurance company then goes and says, okay, well, let's now negotiate our orthopedic services, like $4,000, an arthroscopic knee surgery. And the hospital says, well, you gave us such a good deal on the MRIs. We'll give you a better deal on the orthopedic surgery. We'll do our arthroscopic knee surgeries for a facility fee of $4,000. And the insurance company says, oh, that's a pretty good deal. Okay, we'll agree to that. So we'll give you gobs of money on the MRIs, and then we'll take a sort of a more reasonable, lower amount, relatively speaking, for the surgery. So you do that for labor and delivery and ER services and coronary artery bypass grafts and just staying overnight for a pneumonia, et cetera, et cetera. And what you do is in aggregate, you have about a 50% discount off of billed charges for hospital A. Now, the insurance company goes across town to hospital B and has the exact opposite conversation. So hospital B says, look, we'll take $500 as an allowed amount for our MRIs. And the insurance company says, oh, that's fantastic. That's such a great deal. That's only a quarter of what the other hospital gave us. Of course, they would never say that. Now, but then the hospital B comes back and says, but we want $16,000 for every arthroscopic knee surgery that we do. And the insurance company says, whoa, that is a lot of money. That's 4 times what the other hospital A was asking for. Again, they wouldn't say that, but they would be thinking that. So then say, okay, well, you drive a hard bargain. You gave us such a good deal on those MRIs that we'll give you $16,000 on the knee surgeries. So then again, you do that for labor and delivery and ER services and coronary artery bypass grafts, et cetera, et cetera. And in aggregate, again, you have a 50% discount at hospital B. So when the insurance company then goes to employers and says, okay, we have on average a 50% discount in these, zip codes as a way to show how great their discounts are. They don't say that quote unquote aggregate 50% discount is with huge differences in what those allowed amounts could be within their network. You can see there that there is a 400 or 4x difference between the MRI at hospital A and hospital B, and there's a 4x difference between hospital A and hospital B as well for orthopedic surgery. And so people say to me, well, Dr. Bricker, which hospital is the most cost effective? And my answer to them is well, it depends. And this is why it depends, because of this sort of horse trading activity that goes on between the insurance carrier and the hospital when they're negotiating their contracts. Okay, now, next slide. So now, of course, the major challenge, probably the biggest issue for healthcare in America, is that it is hugely expensive. And so if we're going to work in healthcare finance, then we need to explain, or you need to understand what drives those healthcare costs. And healthcare costs are not some sort of amorphous morass. Okay, they're actually very structured and very organized, and they're actually very understandable. So that's what we're going to do. So one of the principles that everyone needs to understand is it's the Pareto principle. So Pareto was a very famous Italian economist, and the Pareto principle says that a small amount of things produce a large amount of the results. And that's the same thing as it relates to healthcare costs. So only 5% of the claimants, only 5% of the people in a population, let's say within an employer population, generate 50% of the costs. It also is referred to as the 80-20 rule, where 80% of the costs are only generated by 20% of the people. So it's really the high cost claimants. So if you're one of those 5%ers that's driving 50% of the cost, then you're typically having healthcare costs, and that would be typically in excess of $50,000 or $100,000 a year. Now, it could be, and I'm talking allowed amount, not billed charges. Now, that could be just in the course of one claim. You could have one just very, serious illness that puts you in the ICU, and just that one claim for that one hospitalization in the ICU could be like $250,000. Or it could be a variety of things added up. So it could be related to just a very expensive medication that you have to take every month, or maybe you have multiple hospitalizations, or maybe you have a situation where you've got all sorts of complicated medical problems and you're just in and out of the hospital constantly. So each hospital bill might only be 20 grand, but you've had at least 5 hospitalizations. Okay, so it's highly concentrated. Now, there are specific diagnoses that tend to be a part of that 5%. In other words, not all illnesses are high healthcare cost illnesses. And so the diagnostic categories that tend to lead to high cost claimants are 3. They are musculoskeletal, cardiovascular, and cancer. And a lot of the folks on this training actually look at claims. And so this is where those diagnoses are clumped together into groups. And so musculoskeletal is going to be like your orthopedic and spine. So it's going to be your knees, hips, ankles, shoulders, elbows, but also spine is going to go. And spine is a real big one because back pain is very common. Now, there is also a category of diagnoses called injury and poisoning, which sometimes people leave out of their musculoskeletal spend, but it needs to be included for a couple of reasons. One, fortunately, we don't have a lot of poisoning. So there's going to be almost zero, if not zero, healthcare costs related to poisoning. And then that injury isn't necessarily an acute injury, like some sort of fall that results in a fracture. It could also be a chronic injury that will be coded as such. And so you'll think like, oh, okay, well, it's actually a part of my MSK spend, but I didn't capture it because I didn't include the injury and poisoning category. Okay, so it's super important that you also include the injury and poisoning category when you're looking at your overall MSK spend. And historically in America, for employers, MSK was the number 1 cost category for their high cost claimants. Number 2, cardiovascular, things like heart attack and stroke and peripheral vascular disease. The important thing here is that this is where a lot of your diabetes spend is. So sometimes things will be coded as diabetes and it'll actually fall under endocrinologic because diabetes is an endocrine disease. However, diabetes is a huge risk factor for cardiovascular disease. And so the underlying disease process that is leading to the heart attack or the peripheral vascular disease is actually the diabetes. So just know that oftentimes employers are undercounting the cost of diabetes in their claims because they're just looking at endocrine and not realizing that a vast majority of their cardiovascular spend is actually being driven by diabetes. Okay. And then lastly, you have cancer. And the big cancers for an employer population are breast cancer for women, prostate cancer for men, lung cancer, and colon cancer. Okay, so those are the big ones. So lung cancer and colon cancer for both men and women, breast cancer for women, and prostate cancer for men. Now, obviously, you have things like skin cancer, like squamous cell carcinoma, but that tends to be very minor. And you have things like leukemia that are just devastating, but they tend to be pretty rare. Okay, now, just recently, a survey came out that showed that for 2020, I believe it was 2021, that actually cancer spend has eclipsed musculoskeletal as the number one diagnosis cost category for employers in America. And a lot of that is because the chemo has become so expensive. And remember, a lot of that chemo cost is not in your prescription spend, it's actually in your medical claims because it's infusion medications. And again, they're going to have those Hicks J codes on them. And there might be a line item, Hicks J code, for like $10,000 for every infusion of that chemotherapy. And it's really these monoclonal antibodies that, like Herceptin for breast cancer, that are within the last 5 or 10 years have been used much more, that are driving a lot of that spend. So it's not traditional chemotherapy that like makes you nauseous and throw up and makes your hair fall out. It's these monoclonal antibodies that are hugely expensive and actually in your medical claims. Okay. Next up, then you have by provider. So this is how your claims break down in terms of like who you're paying them out to, if you're the government or an employer. So about 50% of your claims are going out, claims spend are going out to hospitals. About 20% is going out to professional fees. In other words, doctors, physical therapists, occupational therapists, et cetera. About 20% is going out to prescriptions. And I should have put 10% for other, otherwise it doesn't add up to 100%. A lot of times, employers, it's 25% for the RX and then 5% of others. So notice here that the largest cost category is hospitals. So if there's going to be any effort to lower healthcare costs, then a couple of things need to happen. One, it needs to be on these high cost claimants because that's where half the money is in musculoskeletal, cardiovascular, and cancer. And then two, it has to be in your hospital claims. So unless your approach to healthcare costs involves those 3 diagnosis categories and hospital claims, you are probably not going to be making a significant dent in your healthcare costs. So that is a fundamental of healthcare finance that everybody on this training session needs to understand, is that it's the high cost claimants for the hospitals that you have to pay attention to if you want to move the needle on healthcare costs. One of my favorite quotes from Steve Covey is, the main thing is to keep the main thing the main thing. Okay, so this is the main thing. It's important not to get distracted. You're going to get reports like this long from your carrier about all your costs. And I made a separate video about this. And what you need to do is you need to close your eyes and not look at the report and say, where in the report can I find the information around my high cost claimant spend for musculoskeletal, cardiovascular, and cancer, specifically for their hospital spend? So you ask that question before you open your eyes and look at the report, because that is the number one thing in that report that you want to look at. Okay, next up. So the reason why healthcare costs are so expensive for employers in America, so the previous studies have shown that it's about 250 to close to 300% of Medicare. So it's 2.5 to 3 times what Medicare reimbursement is. So in other words, for that arthroscopic knee surgery, if Medicare reimbursed $2,000 on average, commercial insurance would reimburse $6,000. So Medicare is paying much less than an employer in America would pay. And the reason is this is because of quote unquote cross-subsidization, where hospitals in aggregate say, well, we don't get paid very much by Medicare, so we're just going to sock it to the commercial insurance and the employers because we can actually negotiate with them. Hospitals cannot negotiate with Medicare. When Medicare says, we're going to pay you $2,000 for that knee surgery, the hospital has to say, okay, that's what we're going to take. And so because they can actually have negotiating power with the health insurance companies, that's where they come back and they say, we're going to make up for that low payment by Medicare by having the commercial insurance companies pay us a lot more. Now, the question then becomes, this is where, everybody cries poor. I cry poor, you cry poor, everybody in the world cries poor. I don't have enough, right? This is a common human ailment, okay? I'm not criticizing hospitals for crying poor, but we need to examine the facts, okay? And the fact is that when hospitals say, well, Medicare doesn't pay us enough to cover our costs, well, then that then begs the question, okay, well, are your costs really that low? Is there any way you could lower your cost structure? And in fact, I was talking to a hospital executive a couple of weeks ago who said that for his very large hospital system, that they actually made money on their Medicare patients. So it's not impossible to still make a profit margin on that $2,000 Medicare reimbursement for the knee surgery. It just depends upon what you're spending money on and what your cost structure is. And that's where hospitals are really in a bind, because the vast majority of hospitals in America do not do what's referred to as activity-based cost accounting. They know their costs in aggregate. They know their costs by how much they spend on their pharmacy in total, how much they spend on laundry in total, how much they spend on nurses in total. But most hospitals in America cannot say, for this particular gallbladder surgery or this particular knee surgery or each day of a hospital stay for a pneumonia, what it is going to cost them. So if they don't know what that knee surgery specifically costs them, then how do they know if the $2,000 from Medicare or the $6,000 from the insurance company is or is not enough to cover their costs? They don't know. They know in aggregate, but they don't know at the specific test or procedure level. They also don't know at the specific doctor level because they don't measure, okay, well, what are Dr. Bricker's costs? What are Dr. Smith's costs? What are Dr. Jones's costs? They don't know. Now, a handful of hospitals know. So the University of Utah knows, the Intermountain Healthcare System knows, the University of Pittsburgh Medical Center knows, the Geisinger Healthcare System knows. So there's a handful of hospital systems in America that have gone through the exercise of activity-based cost accounting. And it's called activity-based cost accounting because the largest cost in healthcare is labor. Healthcare is a services business. And so the cost of the specific surgery, et cetera, is based upon the number of people and the amount of time it takes for them on that specific patient. And that has to be measured through time studies. That's why it's called activity-based. And that's where these hospital systems that have actually done this, they use the timestamps on the electronic medical record, because at hospitals today, almost all the order entry has to be done in a computerized fashion. So you can get timestamps on when everything is done, and you can then use that to then measure the time that is spent on this particular surgery or this particular patient. And then also by each particular doctor, you understand then the resource utilization of Dr. Bricker versus Dr. Smith versus Dr. Jones. And guess what these hospitals found? There's dramatically different resource utilization by physician. So the ordering patterns and the ordering habits for each individual doctor were highly different. So it allowed you to measure then the cost effectiveness of each doctor. And of course, they would adjust it by the risk severity or the illness severity of the patients. Because of course, every doctor says, well, my patients are sicker. That's why my resource utilization is higher. And they can use the data to be like, no, actually not really. You're really an outlier in terms of your resource utilization. And your patients actually are within the bell-shaped curve mean or median of illness. So that was such a huge revolution by the University of Utah that when Michael Porter, one of the most famous business professors in the world from the Harvard Business School, got on a plane and flew out to Utah to be like, what are you guys doing out here that is so innovative? And the University of Utah was like, oh, we're just measuring our costs with activity-based cost accounting. Mind blown, right? So only in healthcare would activity, like all other industries do this, okay? Now, why does healthcare not do it? Because it's hard, okay? I'm not saying it's easy, but it is in order to control costs, in order to lower costs, you have to measure your costs at the specific procedure and doctor level. And guess what? I actually think that more hospitals are moving in this direction. Now, interestingly, what do all those hospitals that I mentioned, University of Utah, Intermountain Health, Geisinger, UPMC, that do activity-based cost accounting, what do they all have in common? They all have their own health insurance company where you can buy health insurance for UPMC in Western Pennsylvania. So UPMC collects premium and takes on risk. So really the key for hospitals to take on risk is they have to do activity-based cost accounting so they can actually measure and reduce their costs so that they can take on risk. This is why so many hospitals in America do not want accountable care organizations. They do not want value-based care because they don't know if they can actually make that work and take on risk unless they do activity-based cost accounting and measure their costs and reduce them. Okay, now, you've asked a ton of great questions here. I'm going to go to them briefly. And okay, this is a great question here from Chris. Thank you so much. Going back to prescription costs. What about autoimmune diseases that often have high dollar medications that are ongoing? Okay, that's a great question. So in that 80-20 rule or 5-50 rule for healthcare costs, you could have a person with rheumatoid arthritis or Crohn's disease or all sort of colitis that are all autoimmune diseases that are treated with injectable medications like Humira that will only show up on your specialty pharmacy claim. So in this case, it's not an infusion that's showing up on your medical claim. It's just on your pharmacy. And the cost of those medications could be so high that they could actually be in, probably not in the 5%ers, but they would be in the 20%ers that are driving 80% of the costs. So, and this is a whole nother topic that I've got a video about as well, that if you look at your pharmacy spend, the vast majority of your pharmacy spend is actually in specialty pharmacy. So if you're going to move the needle on your RX spend at all, then it needs to be focused on your specialty pharmacy. Otherwise, you're not really going to move the needle. Just looking at the questions here. Okay. Wonderful questions and comments. In the interest of getting through more information, I'm going to go back to the slides. Now, keep putting in your comments though. Okay. Now, we're going to specifically go through strategies of various actors in healthcare that try to increase costs. And so we said that the largest bucket of healthcare costs was hospitals. And so you got to understand, right? So healthcare costs are actually hospital revenue. So at the end of the day, if a hospital is in a fee-for-service relationship, they do not want healthcare costs to go down. They want them to go up because that is their revenue. So hospitals they hire consultants that they pay gobs of money. Some of the largest consulting firms in America consult hospitals on how to make more money. And they use these various strategies. Here are some of the strategies. One is horizontal integrations through mergers. So that classic example here would be the Baylor Scott and White healthcare system in North Texas and Central Texas. That's a good example of that. The Atrium Hospital system in Charlotte, North Carolina was a horizontal integration. Okay, there's lots of examples of that. Now, these horizontal integrations have happened so much that, in fact, the majority of metropolitan areas in America actually, because they sort of measure the amount of choice, or rather measure the amount of competition in various industries. And the majority of metropolitan areas in America for hospital services are measured as low competition areas. In other words, these mergers have happened so much that the amount of hospital competition in metropolitan areas is actually low. And it's so low that many hospital systems have then reverted to, and the reason that the mergers allow them to make more money is as a variety of reasons. So on the revenue side, it allows them to have greater contracting negotiating power with Blue Cross United, Cigna, Aetna, so that when they go to the negotiating table and they say they want $2,000 for every MRI, and the insurance carrier pushes back, they're going to be like, look, what are you going to do? Not have us in your network? We like, you're going to have you're not going to be able to sell your PPO network to employers if you say to them, oh, we don't have XYZ hospital system in our network. So they do that horizontal integration so that they can have more contracting clout for those allowed amounts when they sit down at the negotiating table. Okay, so the healthcare cost equation is very basic. It is, and again, everybody needs to understand this. It is the price per unit times the number of units equals total healthcare costs. Okay, so the mergers and the better negotiating power helps with the unit cost. So that increases healthcare costs from a unit cost. So in other words, instead of the MRI costing $1,000, it costs $2,000. Instead of the knee surgery costing $4,000, it costs $16,000. Okay, so overall, those healthcare costs go up on a unit basis through mergers, horizontal. But then vertical integration is then done to increase the patient volume at the hospital. Again, because we said it was the price per unit times the number of units. So the number of patients and the number of patient visits, the number of MRI scans, the number of surgeries. It's those that are the other part of the equation. So if you want to increase hospital revenue or increase healthcare costs, you want to try to increase your unit cost and increase your patient volume. And these vertical integrations are what are done to increase the patient volume. So this is where the hospital systems have gone on a huge buying spree of both specialty practices and primary care practices, because once those hospitals buy those practices, then they either dictate or strongly encourage the physicians to only refer in for testing and procedures, et cetera, at that particular hospital system. So it allows for sort of a funnel, a patient funnel, where they can capture more patients in primary care that then refer to cardiology, that then send them over to the hospital for the cardiac stress test, where they then do the cardiac catheterization, where they then do the coronary artery bypass graft. So it's this patient referral funnel that is used through vertical integration in order to drive more patient volume to the hospitals. Now, 10, 20 years ago, the majority of doctors were not employed by hospital systems. And now it's just over 50% of doctors are employed, not only by hospital systems, but also by private equity firms as well. And we're going to talk about that in a minute. Okay. So this then gets us to fee for service versus value-based care. And so this is where the reason that these horizontal and vertical mergers are done are actually to maximize revenue in a fee for service environment. And in fact, a hospital system chief strategy officer that I talked to, he's no longer the chief strategy officer. He was like, I want to do ACOs and I want to take on risk. And this hospital system hired an outside consultant to look at various revenue strategies. And this outside consulting firm, which is very famous and charges a lot of money per hour, said, we've looked at the data, and the best thing for you to do financially as a hospital system is to milk fee for service for all it's worth. Don't create a health plan. Don't join ACOs. Don't go at risk. You just need to increase your unit cost and increase your patient volume as much as humanly possible. And that is the best strategic direction for your hospital. And guess what they did? They followed the consultant's advice and not the chief strategy officer's advice. So as you can imagine, he left. Okay. So again, healthcare costs do not increase by accident. It is because specific people are sitting in specific rooms, making specific plans and taking specific actions to make them go up. and they don't want value-based care. Now, not all of them do. Some of them want value-based care. And in fact, the Ochsner healthcare system in Louisiana and Mississippi and Alabama really made that flip in the last 3 to 4 years to more value-based care and away from fee-for-service. And it was a huge success, and they're financially doing great. And it was such a success that their sort of physician that was spearheading this, David Carmouche, was then hired away by Walmart Health. And he's one of the senior executives at Walmart Health because he did such an amazing job at Ochsner. Now, what did Ochsner do to facilitate this? They moved their physicians to salary because they knew that and oh, by the way, that's what Mayo Clinic does. That's what Johns Hopkins does. That's what Cleveland Clinic does. So if you want the physicians to provide value and not just do as many procedures as possible, then you need to take the doctors themselves off of fee-for-service and put them on salary. So it's super important concept to understand in hospital finance and healthcare finance. Okay, moving on. Other revenue strategies in healthcare. So, as many of you are aware, there are many private equity firms that have entered into the healthcare space. And what these private equity firms have done is they have purchased physician groups, and they tend to be physician groups related to radiology, anesthesiology, and pathology, sometimes, a lot of times ER physicians as well. And they specifically chose these physician groups because patients do not have a choice in terms of what ER doctor, radiologist, anesthesiologist, and pathologist they have. They don't have a choice. They just go into the hospital, and some radiologist that they never see reads their MRI or their X-ray. Some anesthesiologist that they had no choice in who was going to be in the OR keeps them asleep during their procedure. Some pathologist looks at their biopsy specimen under a microscope. They had no clue who this pathologist is. You can't choose who that person is or what physician group they're in, for the most part. Sometimes with anesthesia, you can. And so the strategy of these private equity firms was then to take these physician groups and then take them out of network. Because if you can still have the patient volume, be like, look, if we go out of network, and then we can charge the health insurance company much more, and we can get reimbursed at out-of-network rates and not decrease our volume, right? Because it's the whole like downward sloping demand curve, right? It's like the greater the price, there should be less demand. But if the person has no choice or no say or never sees the price, then there's not going to be a decrease in demand when you raise the price. And so they took them out of network. And so then you had these ridiculously large, like it would cost like $3,000 just for the ER physician fee out of network. And our family experienced this when we went to the ER here in the Dallas-Fort Worth area. We would get physician fees from the ER doctors for like $2,500. It was more than the ER facility charge. And it was out of network. So, you know, in insurance, you don't have one deductible. You got two. You've got an in-network deductible and an out-of-network deductible. So we could have even met our in-network deductible, and we would still have to pay the full $2,500 from the ER doctor because it was an out-of-network charge. There was no contract between the insurance company and the physician group. And so then the individual patient would have to be on the hook for the full $2,500. Or if you had really rich insurance benefits like they have in the Northeast, the employer was paying for it because the person had a much lower out-of-network deductible. Okay, so now this was the whole reason why the No Surprises Act was passed. And then because all of these patients were complaining to their congressmen and women, being like, I keep getting all these egregious out-of-network bills because all these private equity firms had taken all these physician practices out of network. And so it has still not been resolved. Okay, so even though it's been passed, and I, of course, created a whole other A Healthcare Z video about this, now it's supposed to go to arbitration, okay, between the insurance company and the physician group that's quote unquote out of network, and they're not supposed to bother the patient about it. But guess what? The quote unquote arbitration process has this huge backlog, and they haven't like worked out how they're going to work this out yet. So it's still in flux. It is still not solved. And oh, by the way, like there are still gobs, and that was only if you went to an in-network facility. You could still, if you went to an in-network facility, they said, okay, you have to go to arbitration. You can't get this out of network amount, blah, blah, blah. But that doesn't hold true for out-of-network services. So you could still go for like an out-of-network MRI, and you'd be like, oh, okay, but you still wouldn't know who the radiology firm was reading it. And so you could still get socked with this huge out-of-network bill. Okay, so that's one way. And again, private equity firms have limited partners that invest in their fund. And the private equity firm, their whole goal is to return money to those investors. And then they keep 20% of the excess returns. It's the 2 and 20 rule. They keep 2% of assets under management, and then they keep 20% of all the excess returns that they generate. And so the private equity firm is hugely motivated to increase healthcare costs in America. That's their goal. Okay, next up, pharmaceutical companies. Again, increased pharmaceutical revenue is increasing healthcare costs. Like that's their goal. They have a fiduciary responsibility to their shareholders. If they don't do this, their shareholders will probably sue them. Okay, so you're fine. Again, price and volume. Okay, the price per pill times the number of pills, the price per injection times the number of injections. Turns out in America, we don't take more pills or have more injections than the economically developed other parts of the world. It's actually very similar to places like Germany or Japan or England or France, etc. It's the unit cost. It's the cost per pill or the cost per injection that's so much higher. So why are those costs per pill and per injection so much higher? One, we have patent laws in America, but the pharmaceutical companies create what are called patent thickets, where that patent for 17 years is extended. And in the case of drugs like Humira, it's extended to like 30 to 35 years. Now, Humira is coming off patent, but it's been much longer than 17 years that Humira has been on patent, where you don't have one patent, but you don't have a dozen patents. You literally have dozens of patents that this and this and this and this and this. So if one patent expires, you got another one coming in on the same medication. And then you got another one coming in on the same medication. So it creates this patent thicket. And then even when all the patents are expired and generic companies can then start to make the medication, pill or injection, then there are schemes referred to as pay to delay, where the company that makes the brand name medication will actually pay a generic maker of a medication to not make that medication. It's essentially a bribe to have them not make the medication. It's pay to delay so that they can continue to charge $500, $1,000, $2,000 a month for this medication. Okay, now, in order to generate demand for these very high cost medications, they used to pay doctors. But then the federal government passed the anti-kickback statute that says, well, you can't basically pay the doctor a commission. So what they've done is the pharmaceutical companies have moved to, instead of paying a straight commission, they have moved to paying speaker fees and consulting fees to doctors. But in many situations, unfortunately, that is essentially a thinly veiled commission for essentially prescribing more medications. So in America, every pharmaceutical company and every pharmaceutical sales reps knows exactly how many prescriptions of every single medication each doctor has prescribed. We have data gathering companies. IQVIA does this. And IQVIA gathers that data and then sells it to the pharmaceutical companies. So the pharmaceutical companies can then give that to the drug reps, and they'd be like, okay, we know that Dr. Bricker doesn't prescribe any of this, and Dr. Jones prescribes 10 prescriptions a week of this. And so the pharmaceutical reps can then go out and strategically target me to get me to go from 0 to 10, and then strategically target the other doctor to go from 10 to 20, and they can measure their results. And then they can, quote unquote, pay the doctor who goes from 10 to 20, a speaker fee or a consulting fee. And then if I hold my ground, I'm like, I'm still at 0, then I don't get anything. And so now these pharmaceutical companies have, quote unquote, settled and admitted no wrongdoing with the federal government for these types of things. But just know that this was a very common practice. Okay, lastly, medical device companies. Okay, knees, hips, spine. The reason why a knee replacement costs 75 grand, or the reason why a hip replacement costs 35 grand, or the reason a spine surgery costs 100 grand is because there are specific line items for the implants themselves that are very expensive. So like at a place where the knee replacement costs 75 grand, it's because there's a line item for that knee itself for like 30 grand or 50 grand that the hospital has negotiated with the insurance company. So you're like, and of course everyone's like, okay, well the knee implant is 50 grand because there's all this technology and it's hugely expensive, et cetera. Well, in this example here, you got to understand that to actually make that implant, it only costs the manufacturer like $300. And then they sell it to the hospital at a 10x markup. So they sell it to the hospital for $3,000. And then the hospital then marks it up 10x to $30,000. So this $30,000 implant wasn't some hugely, technology, blah, blah, blah. It was a $300 piece of equipment that just got marked up. It was not that expensive to make. So these are other actors in healthcare that drive up healthcare costs, and this is how they do it. Okay, now, of course, I'm going to end with a whiz bang here. It's super important to also understand how pharmacy benefit managers, which at the end of the day shouldn't even be called pharmacy benefit managers, they're insurance companies, right? The three main PBMs in America, they're all owned by health insurance companies. So you should replace PBM here and call it health insurance companies. So actually, health insurance companies make a lot of money by healthcare costs going up. Everyone thinks that, health insurance companies want healthcare costs to go down. Well, health insurance companies are very clever, that they can make money by having certain aspects of healthcare go down while they make money by other aspects of healthcare going up. So they kind of play this juggling act. Okay, they're like, okay, well, we make more money if we make healthcare costs go down over here, like for our Medicare Advantage enrollees, but we make healthcare costs more if our commercially insured employer clients take more medications. So we actually want healthcare costs for RX to go up on the employer side, and we'll just keep money down on the Medicare Advantage side so that we can make money on that. Okay, so it's really a mixed bag. So PBMs make money two ways, through rebates and through spread pricing. And this is probably the most complicated part of the talk. So I encourage you to really focus here at the end. And we're first going to talk about rebates. And this is done for brand name medications. So it could be brand name insulin, brand name injectables like Humira. It could be brand name pills as well, where let's say the medication costs $400 a month. Now the PBM at the employer, so the employer and the patient, between like what they're paying together, it's $400 a month for that medication. Now the PBM is taking a quote unquote $100 rebate. Now they quote unquote provide savings to the employer because they provide some of that rebate back to the employer. So in this example, they provide $25 out of $100 for that rebate. It could be $50, it could be $75, but they provide a certain amount of that rebate back to the employer and be like, look how much we're saving you. But then they also keep a certain percentage of that rebate as well. In this case, they keep $75 out of the rebate. So in that financial relationship, the PBM / insurance company is motivated to have the cost of that medication go up. And they're also motivated to have as many people take as many medications as possible. What if you did an intervention through diet and exercise that actually caused people to use less insulin, that used less medication? That would cause the health insurance company to lose money. It is not in the financial interest of an insurance company and their shareholders for people to use less medications. They should use more medications for more money. And that's good for the health insurance company, and that's good for the shareholder. So that is the financial arrangement. And that financial arrangement is not good for employers and patients, which is why more and more pass through PBMs. The Purchasers Business Group on Health, which is a large coalition of some of the largest employers in America, like Boeing, are creating their own PBM because they realize that the financial relationship of their PBM with them as employer purchasers, they're not aligned. And so they are changing the way they process their claims for prescriptions, okay? But it's super slow, okay? There is still the vast minority of employers in America that use a pass-through PBM that does not keep any of the rebate dollars. They just charge a per script fee, okay? So they're still making more money the more prescriptions are written. But it's like, look, you know that we're charging X dollars per prescription, and here's the number of prescriptions, here's how much we're charging per prescription. That's what we're charging. That's what we're getting paid. So it's transparent. Okay, now spread pricing. This is even more complicated. Okay, this is used on generic medications, and this is where there is a spread between what the plan is paying the PBM and what the PBM pays out for the generic medication. And it's that spread between the two that generates revenue for the PBM/insurance company. Now, you have to understand some terms in order to understand spread pricing. So the first is AWP, and that's like the fictitious list price for the medication, okay? And then the PBM, quote unquote, negotiated a quote unquote discount off of AWP, which might be as much as like 80% off of AWP. And then there's the MAC, which is the maximum allowable cost. And that is the cost that the PBM then pays out to the pharmacy. So they're taking the AWP minus the discount from the employer, but then they're paying out the MAC. And the MAC is a proprietary amount. They absolutely do not tell that to anyone. Now, there is the NADAC, the National Average Drug Acquisition Cost, and that's what it cost the pharmacy to actually buy the medication from the wholesaler, like AmerisourceBergen, McKesson, and Cardinal. Those are the three big drug distributors in America. And they're the ones that are basically the big warehouses that get all the pills from all of Pfizer, Merck, AstraZeneca, et cetera. Now, so then the PBM profit is just the AWP minus the MAC plus the dispensing fee, right? So there's also, the pharmacy also charges a small dispensing fee. And then the pharmacy profit is the MAC plus the dispensing fee. That's what they're getting in, minus the acquisition cost, or the NADAC. Now, let's use a specific example to illustrate this, because I think that'll be helpful. And this is a true example from 46 Brooklyn, which is a fantastic pharmacy cost research center in Ohio, for amlodipine, which is a very common blood pressure medication that is now available generic. When it was brand name, it was called Norvasc, okay? So the average wholesale price for the amlodipine is $2.38, which the PBM negotiated a discount of 80% off of that. So the plan is paying out 48 cents per pill of amlodipine. Now, and so here we have our drawing here. So you've got the $2.38 times 20% gets you the $48 cents per pill that the plan is paying out to the PBM. Now, the PBM is only paying out 25 cents per pill in MAC and dispensing fee to the pharmacy. And again, that number there is proprietary, so I made that up. And then the 23 cents, in other words, the 48 cents minus the 25 cents, the 23 cents is the spread in the price that is the revenue for the PBM. Now, the pharmacy is getting 25 cents per pill, and then it only costs them in an acquisition cost from the wholesaler of 0.019 cents. In other words, 2 cents. So by the time everything is said and done, this employer is paying 48 cents per pill for a pill that only costs 2 cents per pill. So here you are. All these generic medications are so inexpensive. They're so much cheaper than they actually think that they are. Now, that spread pricing was then revealed in the state of Ohio, and the state of Ohio found out that their Medicaid program was overpaying $208 million for their generic medications, and they settled with the health insurance company / PBM that was running their Medicaid program. Now, other states have followed suit. And in fact, Texas, where I am, just settled with the insurance company, one of the insurance companies that runs one of our Medicaid programs. And other states are doing this well. And if this holds true for the state Medicaid plans, it is holding true for the employer-sponsored plans as well. So that is PBM spread pricing. Now, we're nearing the top of the hour, and so I went over a whole bunch. I will just briefly say solutions to this. There are solutions. It's not all doom and gloom. Employers have flattened and even lowered their healthcare costs by doing a combination of these four things. One, greater use of primary care through on-site clinics, near-site clinics, virtual primary care. Two, direct contracting for guaranteed bundled rates for major surgeries like knee replacements and spine surgeries. Walmart does this, Lowe's does this, and then on the hospital side, the Trinity healthcare system at one of their hospitals in Connecticut does this as well. They contract with employers as a center of excellence, and they do guaranteed bundled rate pricing. Okay, next up, you can do steerage within your PPO network to the highest quality, most cost-effective providers. And this is what we're doing at Simple Pay, where we're actually getting rid of the deductible, and we're just doing tiered copays to direct people to the highest quality, more cost-effective providers in their very large PPO networks that have huge variability in terms of cost and quality. You'd be like, okay, well, who's good in the network? And then you'd want to tie the copays to those amounts. That's what we're doing. And then lastly, more employers are moving to self-funding. In order to use a PBM that's transparent, you have to be self-funded, and then you have to carve out your PBM. But more employers are doing this as a way of controlling their RX spend. And so with that, we have reached the end of the presentation. All of you from around the world and across America have been so wonderful in joining me here. And I just want to say, look, if you haven't connected with me on LinkedIn yet, please do. I post a bunch of videos there, one video a day, 5 days a week. Feel free to email me with your questions. You can see my email address there, ericb@ahealthcarez.com. I didn't get a chance to answer as many questions as I wanted to because I packed so much information in, so I apologize for that. Please feel free to either message me on LinkedIn or to ask me questions by email. I'd be happy to answer those. And with that, I just hope you have a fantastic rest of your day and a fantastic weekend. Thank you so much for watching.